Good afternoon, everyone. Welcome to our series of global health seminars. We are privileged to have Dr. Connie Osborne, Lusaka, Zambia, and just to introduce that this is Department of Global Health at Stellenbosch University in Cape Town, and we can have these three global health seminars, and so very privileged to have Dr. Connie Osborne from Lusaka to share with us many years of experience in global health. As you read from her profile, she's a well-accomplished medical doctor and public health expert in the field of HIV, where she has worked for many years, both locally and internationally. So her career started within Lusaka, where she qualified as a doctor and specialized in pediatrics, and later on migrated to do epidemiology at London School. And so you will see that her career really revolves from childcare to women care, policy to academia, and really it's a privilege that we can have someone who has such level of expertise and the experience to share with us this year. And so this, I mean, today, and this will be experiences gained from United Nations, from Amref Health Africa, where she was the regional director for Southern Africa, and then later as Director General for HIV and AIDS Commission in the Republic of Zambia. So I really want to take too much time. I know the CV is her profile is part of the advert there, so you can read more. And just to say that she's someone who likes collaboration. So beyond this seminar, please do feel free to get in touch with Dr. Osborne if there are areas that you would want to collaborate with. So Dr. Osborne, thanks very much for your time, and let me leave this time to you now to give your seminar. Thank you.
Thank you very much, and good afternoon, everyone. First of all, allow me to say how very honored I feel to have been given this opportunity to share the current status of alcohol and substance abuse among adolescents and young people in Zambia. That's my title. The subtitle is Prevention, Treatment, and Recovery Best Practices from Other African Countries that Zambia could learn from. So thank you so much, Peter, for reaching out to me. I'm very excited. Next. So after a brief introduction of the drug and alcohol abuse from a global perspective, I will then share where Zambia is at in terms of addressing the problem. I will then try to share the best practices from other African countries and the lessons that Zambia can learn as it moves forward in trying to address this problem. I will, of course, end with some few concluding remarks. Next. So, repeated and compulsive use of drugs and/or alcohol is a global public health problem. Its negative health consequences and the heavy financial burden on individuals, families, and society is felt in nearly every country. Currently, over 100 million adults are said to be affected globally, with rapidly rising numbers among adolescents and young people. Substance use is, as you all know, one of the main risk-taking behaviors during the adolescent period. And we're talking of from age 10 to about 19. I'm sure some of you, they've been there, done that in terms of experimenting with drugs and alcohol. This causes maladaptive behaviors such as robberies, missed education and career opportunities, and of course, an increased occurrence of unprotected sex, which can lead to unwanted teenage pregnancies, sexually transmitted illnesses, including HIV, hepatitis B, and hepatitis C. Next. So cannabis remains the most widely used illicit substance in Africa, with the highest prevalence in Western Central Africa. And amphetamine type stimulants like ecstasy rank as Africa's second most widely abused drug type. Injecting drugs, of course, they carry with it the risk of infection with viruses such as HIV and hepatitis B and C, which is also, like I said, sexually transmitted, as well as one can get it from sharing needles and syringes. According to the World Health Organization, the harmful use of alcohol results in about 3.3 million deaths each year. On average, every person in the world aged 15 and older drinks about 6.2 liters of pure alcohol per year. At least 15.3 million persons have drug use disorders, and injecting drug use is regularly reported by about 148 countries, of which 120 countries also report HIV infection among this population. With an estimated, now I'll go to the situation in Zambia, with an estimated population of about 17.4 million, 15.5% being females, and most of the population being in rural areas at about 57%. Drug and alcohol abuse among adolescents and young people in Zambia is a significant public health issue, which unfortunately has not received the attention that it ought to. Despite the paucity of data, high rates of drug and alcohol abuse have been reported among Zambian adolescents and young people. And alcohol is the number one cause of outpatient attendances and hospital admission to psychiatric departments of units of most of the hospitals in the country. The prevalence of regular alcohol use is highest among adolescents in Zambia, according to one study about 2 years ago. So peer pressure, financial, family, relationship pressures, school and work pressures, all these have a role in determining the prevalence of substance use among adolescents and young people. As well as experimentation or just being curious, emotional trauma, trying to manage this, and other predisposing factors like if there is alcohol abuse running in the family, this also plays a role. Sometimes the problem runs in the family. The next two slides are just some stats from mental units, psychiatric units and departments of hospitals in Zambia. As you can see, alcohol use and mental disorder is the leading cause of outpatient attendances, or rather it was in 2021. And drug use mental disorders was number 3. Next. When it comes, next slide. When it comes to inpatient admissions, again, alcohol use, mental disorders, they are the number one reason for admission into psychiatric departments. Next. So the contribution of alcohol to patients being seen at Zambia's largest hospital, called Chainama Hills Hospital, as outpatients has actually increased from 38.3% in 2018 to 40.7% in 2021. The inpatient status has nonetheless remained static at 26.2% over the same period. The presentation of alcohol-induced disorders at hospitals, as you can imagine, is just a tip of the iceberg, which is an indication and an indication of the rampant abuse of alcohol in the general public. And due to stigma attached to this big hospital, the main big mental hospital called Chainama, a significant number of clients and their caregivers, they shun the services provided by the hospitals, resorting to going elsewhere or in private, to private clinics. There are therefore more clients affected in Zambia who are not seeking professional help. Next. The commonly used substances are alcohol, cannabis, heroin, cocaine, and then we have a number of street concoctions, and they carry different names. And of course, benylin with codeine is very much misused by adolescents and young people. So it's not just the illicit drugs, but it's also drugs which are normally given, like cough mixtures, and some people might actually even be addicted to painkillers. Like, next, please. Next. So the government has so far tried to strengthen the establishment of youth-friendly services in health facilities and other open spaces as a way of discouraging these maladaptive behaviors like drug and alcohol use. They've also recently introduced a free education policy so that most adolescents remain in schools. And the Ministry of Health and the Drug Enforcement Commission do regularly conduct joint sensitization campaigns in schools and other youth social centers, such as churches and recreation facilities, just to talk about the dangers of, alcohol and substance abuse. In schools, counseling and guidance departments and even subjects have been introduced that contain information on alcohol and substance abuse. Zambia has a national alcohol policy aimed at regulating and controlling alcohol production, distribution, sale, and consumption. And this, of course, the approach in the policy which is encouraged is a multi-sectoral approach. The drug enforcement has also intensified efforts to curb the sale and supply of illicit drugs. Next. Currently, Zambia, of course, has a national policy on alcohol, but not on substance abuse, like, illicit drugs. Currently, we also don't have very well established alcohol and substance treatment facilities. Drug and alcohol abuse related disorders are usually treated in hospital psychiatry, mental health units, which are in most cases not even adolescent friendly. There are some private health facilities, not many though, and which exist, but most affected adolescents and young people are not able to access them, as these are very expensive. The government of Zambia at the moment does not even have a rehabilitation center, and most patients are therefore managed in these mental health units of most of the hospitals in Zambia. Going forward, the government, through the Drug Enforcement Commission, has been putting in place detoxification centers in provincial centers and intends to commence the construction of a national rehabilitation center in Lusaka. A national strategy for prevention, treatment, and care and support of drug and alcohol abuse among adolescents and young people in Zambia is therefore urgently needed. The process has started, and in the next 2 weeks or so, there will be a stakeholder meeting on drug and alcohol abuse among adolescents and young people. This will be a very important first step. Now, from 2017 to 2019, the African Union Commission, with support from the United Nations Office of Drugs and Crime, published a compendium of good practices on drug use prevention, drug use disorders, treatment, and harm reduction in Africa. Drug demand reduction, national focal points in various countries were very instrumental in putting these best practices together. So the compendium, which was published, I think, in 2019, consists of best practices from about 12 countries, namely Algeria, Angola, Benin, Cote d'Ivoire, Egypt, Kenya, Mauritius, Namibia, Nigeria, Tanzania, Zanzibar, and Zimbabwe. I am going to share with you best practices from about 3 SADC countries. I chose Angola, Namibia, and Zimbabwe. And also I chose one East African country, Kenya, and one West African country, Nigeria. And of course, from North Africa, Egypt, which is not part of sub-Saharan Africa. So for Angola, their best practice was around drug policies and practices. Drug use in Angola is a serious problem for many families, regardless of the level of income, be it low, middle, or upper income level. The problem is serious in all the levels. Cannabis and alcohol are easily available. The government, to address the problem, has put in place the following measures. They have strengthened basic education to include training of the teachers for age groups 4 years to about 15 years. And they have also inserted aspects of drug use prevention, treatment, and recovery. And with inclusion of drug use prevention materials in the school curriculum of basic education. The other policy they've put in place is in relation to strengthening the role of families and communities in drug use prevention activities. They have increased availability and accessibility of medication-assisted therapy, both for detoxification or as opioid substitution therapy, and established a National Institute for the Fight Against Drug Use. Next. The role of this institute is to ensure 3 things. First, that drug prevention and use are carried out following best practice models. The other role is to reduce juvenile delinquency through working with families who do not offer sufficient protection or social safety nets to their young children. And 3, to achieve greater efficiency of this model by working in close partnership with other state institutions that form the Interministerial Committee on the Fight Against Drugs, and with social partners, churches, NGOs, and private associations. So the full involvement of the various authorities at national level with a strong government commitment, together with the active engagement of the family, civil society, young people themselves, has led to the success of these policies that the government has put in place and actually has been held as a best practice by AU. That's why it was part of the compendium. So coming to Namibia, the best practice is around a program called Coalition on Reduction of Harmful Drinking, the CODE program. This was initiated in 2004 due to the increased concern by the government of Namibia about the level of alcohol consumption in that country. So the Coalition of Reduction of Harmful Drinking, CODE, they have committees which have been established in all the regions using a multi-sectoral approach with stakeholders from various sectors of society, including government, community-based organizations, other non-governmental organizations, private sector, development partners, and international agencies who play different roles in reducing harmful use of alcohol in Namibia. CODE committees and health professionals are trained to screen and refer individuals to support groups such as Alcoholic Anonymous groups and clients to inpatient treatment centers or to the local social worker for community-based therapeutic interventions. Next. So I just picked some selected CODE activities, and these include things like opposing new applications for licensing to sell alcohol at shebeens or bars which are near schools or religious places. They also, with the help of committee members who are police officers, they do regular mappings of areas with bars and shebeens that are prone for crime, and then, of course, get the government to increase police presence in those areas. Other activities include identifying and informing police about shebeens and or bars that sell alcohol that are not licensed or do not keep to trading hours and or are selling alcohol products to teenagers. They also organize community meetings and make school site visits to emphasize the dangers of alcohol drinking. Last but not least, they're involved in increasing awareness and mobilizing communities on the effects of alcohol and drug abuse. For example, telling people that when you abuse drugs and alcohol, you tend to have higher numbers of sex partners, greater frequency of sex with casual partners, and of course, decreased condom use compared with non-drinkers. The third country I chose was Zimbabwe, and their best practice was on a substance and alcohol use disorders intervention in people living with HIV at an HIV care clinic. So this was a randomized controlled trial. So substance and alcohol abuse, as we all know, are associated with risky sexual behavior, poor adherence to highly active antiretroviral therapy, and also treatment failure when someone is on these ARVs, and increased physiological harm to themselves. A psychotherapy intervention for HIV-infected patients with substance use disorders, and developed through an adaptation of existing evidence-based psychological treatments, was piloted at a tertiary HIV care clinic in Zimbabwe. The primary outcome measure was the alcohol use disorder identification test, also known as audit. And then, of course, CD4 count, viral load, and the WHO disability assessment schedule and WHO quality of life. All these were secondary outcome measures. The intervention was a blended motivational interviewing developed through adaptation of evidence-based therapies. Trained registered general nurses delivered the intervention. Next. So out of 40 out of 102 screened persons living with HIV who were attending this HIV care clinic were recruited, and outcomes for 31 patients were assessed at a 3-month period. 9 out of the 40 were lost to follow-up. The study showed that the intervention led to a reduction in substance and drinking in people living with HIV/AIDS, and this intervention could actually be administered by nurses. It is a best practice in that trained general nurses were used to deliver the therapy instead of psychologists, who are usually in short supply. Next, now we go to East Africa, Kenya, and their best practice is around medically assisted therapy program. So in Kenya, persons who inject drugs have significantly higher HIV prevalence compared to the general population. We're talking of 18.3% versus 6% in the general population, with females who inject drugs disproportionately affected. So about 44.5% versus 16% for their male peers. Adverse effects of drug use on society, as in other countries, include things like homelessness, family breakdowns, loss of productivity, criminality, higher morbidity, and premature death. So in 2010, an unprecedented heroin crisis in Kenya took place. This was following the government's crackdown on drug trafficking barons, and this highlighted a very weak public health response capacity to managing persons who inject drugs. Some of these weaknesses were related to congested health facilities, human resource constraints, no medications for opioid withdrawal management, highly mobile clients, and a large proportion of polydrug users. So, resulting from this, a unique collaboration between the Ministry of Health and county governments in Kenya. Counties are like districts, and USAID, PEPFAR, UNODC, the University of Maryland, civil society organizations, and persons who inject drugs networks. So a collaboration was developed for the rollout of medically assisted therapy program in Nairobi and the coastal regions as part of the comprehensive combination prevention program. Next. Next slide. So the implementation followed the following process. First of all, the first strategy was adopting policies, strategies, and guidelines to increase persons who inject drugs access to evidence-based interventions. Strategy 2 was increasing access to comprehensive persons who inject drugs package of HIV prevention, care, and support services. The third one was strengthening policymakers and community support for persons who inject drugs, HIV prevention interventions. And number 4, improving capacity to monitor and evaluate persons who inject drug programs. They took lessons from Mauritius, Spain, UK, Vietnam, and Tanzania, and these lessons reinforced the government's conviction and confidence in Kenya's medically assisted therapy program. And the persons who inject drugs were prioritized also in national AIDS strategic plans. A national policy for HIV prevention for key populations was developed and implemented, and technical guidelines standardized with standardized operating procedures and roadmaps assured a smooth rollout of the intervention. So over time, national health authorities, with the support of UNODC, have engaged trained local resource persons to increase in-house capacity at the subnational level. So this really has been, the Kenya has been one of the best practices. If we go to West Africa, there is a best practice which is around integrated community-based response to drug use among young people. So the integrated community-based response to drug use among young people is a youth-centered approach that integrates advocacy for policy reform, community-based public health programs, and social integration. So the NGO that runs this, which is youth-led, is called Youth Rise. So Youth Rise implements a three-pronged intervention model. The first being meaningful engagement of informed, knowledgeable, and affected youth in advocacy and development of the national drug policy. So the engaged young people are knowledgeable in terms of in design, implementation, monitoring, and evaluation of programs within the context of their social environment. The other activity intervention is community-based outreach services, which they carry out. And then they've also established drug user-friendly one-stop shops for holistic interventions. So the youth subpopulations which the NGO targets during their outreach activities include young people who use drugs, and then you have young people, we're talking of drugs, oral, taken orally like cannabis or smoked like cannabis. And then you have young people who specifically inject drugs, young females who use drugs, both injecting and non-injecting. And then you have young females who use drugs and sell sex, and young people who have not initiated drug use. So they have these different categories of young people in terms of when they're analyzing their statistics. Besides the mobile services which they provide by their outreach teams at community level, the NGO has a treatment, has these treatment drop-in centers for drug users where an array of services are provided, including HIV and other health-related services. And knowing fully well that many young people who use drugs do not have substance use disorders and hence do not necessarily require drug treatment, the center provides brief interventions in terms of screening to identify current or potential problems with substance use and motivating the individuals to adopt healthy behaviors. Since the commencement of the one-stop shops, there has been an increase in enrollment rate of injecting drug users of different categories, as well as their partners who may be HIV positive. The social integration activities that they carry out at the one-stop shops, these focus on family reunions, economic empowerment, and access to education. Through this, many youths in Nigeria have reunited with their families, and families have been educated on drug use and how to relate better with their children or individuals who may be abusing the drugs. Next. The last best practice is one in Egypt, and this one is around gender responsive services for women with substance abuse disorders in Egypt. So women with substance abuse disorders face more stigma and discrimination than their male counterparts. And I think these people can relate even in other countries. It's okay for male counterparts to be drinking alcohol and taking drugs, but when it's women, the stigma and discrimination becomes much more. In order to address this, a decision was made to provide gender-specific substance use disorders treatment to this population. A dedicated treatment facility for women was established. Gender-sensitive treatment modalities were developed. Staff were trained, and an adapted model was set up. This model was adapted, or rather it incorporated features from models being implemented in Sweden and Pakistan, with experiences derived from training in Malta. It was decided to locate this service in an independent building within the current addiction hospital in Cairo, and infrastructural changes were undertaken to enhance privacy and facilitate access to the service by women. A therapeutic team was created and staff were trained in gender responsiveness in the context of substance use disorders in women. Next. So within a year, the new outpatient cases increased from just 5 to about 249 cases. And follow-up outpatient cases increased from 28 to 470 cases. Female inpatients with substance abuse problems increased from 7 to about 51 cases. The treatment program in the inpatient ward was strengthened. Each patient was able to receive individual psychotherapy and to attend group activities. And some of these group therapy programs consisted of various approaches, including motivation groups, psychological coaching, cognitive behavior therapy, and emphasis on the here and now, couple and family counseling, family psychoeducation, parenting skills and childcare skills. And the rehabilitation activities, they included things like creative arts activities, including painting, handicraft, writing, were also offered once weekly. and the ward library was improved in order to enhance the reading activity of clients. So there were also even cooking activities. Social workers, they developed a telephone service in order to communicate with the patients' families, and patients' families were also invited to attend a collective Ramadan breakfast with patients. So there were lots of activities. So what are the lessons that Zambia can learn from these best practices? First of all, the need for a multi-sectoral and multidisciplinary evidence, public health, and human rights-based approaches. And I think most countries tried to do this. The issue of strong community participation was seen in most of the best practices. And then self-reliance of community members in income generation in order to sustain the interventions. This was particularly so with the Angola best practice. The role of families, establishment of regional and or district level drug abuse committees like in Namibia, and then mainstreaming drug and alcohol abuse IEC materials in the basic education curriculum as in Angola. The gender, Zambia can also learn from the gender responsive interventions which were established or introduced in Egypt, and also the introduction of substance use disorders, or alcohol use disorders interventions in HIV care programs, as in the case of Zimbabwe. And there's also lessons to be learned from the youth-led interventions in Nigeria. Next, I'm almost there. So in conclusion, we know that a wide range of effective global, regional, and national policies and interventions are in place to reduce the harmful use of alcohol, with a promising, and there has been a promising trend over the past few decades. In 2010, delegations from all 193 member states of WHO reached a consensus at the World Health Assembly in that year to develop a global strategy to reduce the harmful use of alcohol. A significantly higher percentage of countries have now written national alcohol policies and are imposing stricter blood alcohol concentration limits. Illicit drug trade has continued to be, continues to be big business, and demand for the drugs and alcohol continues to be high. Supply, demand, and harm reductions are the cornerstones of addressing drug and alcohol abuse and the substance use disorders. Suppression of drug trafficking trade requires the full cooperation of countries at both the regional and international levels. And for Zambia, harm reduction, which has to date not received the attention that it ought to, will soon be energized by the upcoming proposed stakeholder meeting to develop, which intends to develop or move towards the development of a national strategy for the prevention, treatment, care, and support among adolescents and young people. This will be a very important first step. Next. So thank you so much for listening to me. I would like to acknowledge the Ministry of Health and National HIV/AIDS Council for some of the stats that I quoted, and of course Chainama Hills Hospital, which is the biggest mental hospital in Zambia, and an NGO called My Zambia, My Responsibility, which really has been trying to address this issue of drug and alcohol abuse in adolescents and young people. Thank you.
Thank you very much, Dr. Osborne. That was very exciting to listen to. And this is vast amount of information, very exciting knowledge, and a very important topic. And I liked the triangulation of drug abuse and how it is a risk to HIV acquisition. And I think that is a very important point to note. So let me open the floor for questions from the audience. You can raise a hand and ask the question, or you can type the question on the chat and then I will be able to read, or you can read the question directly. I see there's already a question there by Dr. Juliet Nyasuru. You can ask the question.
Okay, thank you so much for the opportunity. Thanks, Dr. Osborne, for the presentation, and eye-opening indeed, a lot of strategies. And my question is in line with stigma. You know, there's a lot of stigma around mental health and drug abuse, alcohol. As a result, I've observed it here in South Africa, but also very apparent in Malawi. The little services which are available can hardly be accessed due to stigma. So what would be your comment, and what would you say that could be, maybe from your strategies, what would be the recommendation or something that we can do to ensure that the little services are accessed by the people? Thank you so much. Over.
Yeah. Thank you, Juliet. Yes, indeed, stigma and discrimination is one of the structural barriers to accessing mental health services. And you are right in saying that this actually stops people from accessing those services. When you look at the best practices which are shared, and I only shared 6 out of the 12 that I had seen, the issue of, first of all, the government taking the lead in having, the necessary policies in place, and also the role of families and communities in terms of the dangers of substance abuse. I think stigma and discrimination in HIV, occasionally we do like a stigma and discrimination index survey, and I think probably one needs to also do that in terms of stigma and discrimination against people with mental disorders, so that we can really dig further into what is it about mental health that makes people be scared and start discriminating. Because stigma and discrimination, bottom line, it's underlying causes are like, you think that you might catch it, or you might also have the same problem. So I think that leadership, first of all, by the government, and in government, the people that form government, the lawmakers, the lawmakers, these are members of parliament, and members of parliament are the link between the government and the people. So probably also sensitizing members of parliament so that they talk about these issues, to address stigma and discrimination. To me, I think that would be the right way to go. But otherwise, when you look at the best practices, what I saw, the fact that families and communities, and also especially the importance of involving the beneficiaries themselves to be champions, especially if they can be treated and survive, or rather, be alcohol free. They can then form the champions for trying to address stigma and discrimination.
Thank you. Thank you. I have another question there. I hope that clarifies your question, Dr. Juliet. Varia Bupe, you can open the mic. Yeah.
All right. Thank you so much, Prof. And thank you for enlightening us, Dr. Osborne. That was a very nice presentation. So I've got a few questions and then comments. So based on your presentation, I think I'm suggesting that maybe we can also try to look at household factors, and then how do these factors try to influence adolescent and young men and women in terms of drug and alcohol, or let's say just drug abuse that is related to alcohol and any other illicit drugs that they might be using. And in these, I can try to look at maybe some of the community level factors, for example, by region, by socioeconomic status, and also coming from an academic institution. I lecture at Mulungushi University. I think these are some of the problems that our students, not only those who are in socially disadvantaged or economically disadvantaged, these are also happening in most of the universities, including the universities that we have here in South Africa. So how do we help these students? Because if they are able to use these drugs, they've just been given the freedom to be independent. There are higher chances that they might have engaged in other practices which may even put them at higher risk of contracting HIV if they continue using these drugs. Then working really together with government, one thing that I'll ask is, in terms of policy, how have we, as a Zambian government, or how have you tried to engage the Zambian government in terms of familiarizing this policy with the people who are at risk or at higher risk of using drugs, and also most especially the youth? Do they know what the policy is all about? How is it being implemented? How were they engaged? Because if they are not engaged, and we are talking about these youths, and then they don't know what exists in the policy and what help they can get, where they can find it, I think it will still be a challenge and will still be grappling with this problem going forward. Then the third is just a question to you. How many rehabilitation centers do we have in terms of drug abuse within the country? Because I know that mostly these are China, where I think is to do with mental health that comes with using drugs and stuff like that. Are we able to manage with just one facility to rehabilitate most of the youths that might be having these challenges? Then just to sum it up, I know we developed the 8th National Development Plan. I don't know how we try to infuse some of these issues to do with drug abuse. Most especially, we know that about 45% of Zambia's population is below the age of 25. And these are the utmost risk population. So we need to take advantage that comes with these people in terms of information generation, and also engaging them on what forms of help they can get to reduce drug abuse, and also so that they're rehabilitated and become useful citizens in a country. I think those are the few comments and questions that I had for you.
Thank you.
Yeah. Thank you very much, Walia. I could not agree with you more in terms of looking at factors at household level as well as community level. I mean, there are so many factors that may lead to young people, repeatedly taking alcohol. So unless one does a study maybe a knowledge, attitude, and practice studies, or factors that are associated with compulsive alcohol use, at least we can get somewhere there. So I agree with you. We need to look at household facts. In fact, so in the household, if the adults in the household drink alcohol and there's always alcohol around, you don't expect the children to escape from that. They too will start drinking it. You talked about the government, where the youth involved in the development of the national alcohol policy. To tell you the truth, I wouldn't be able to answer that. Most likely they may have been, but we have in the audience, I don't know if Gabriel is there. He is with the Ministry of Health, and he is the alcohol and substance abuse focal point for the Ministry of Health. He might wish to add something to that, but we can tell that from this extent of the problem, and I'm speaking from an HIV perspective, where close to 40% of all new infections in Zambia, all new HIV infections in Zambia are in young people and in adolescents and young people. So this says something, because we know that drug and substance abuse will make you engage in HIV high-risk behaviors, never mind the sharing of needles and syringes if one is injecting drug use. So the thing about, even if the young people were involved, the thing about young people is they are a moving, a transient population. So the young people at the time when the policy was put in place are now adults. So you have a new group of young people. So the extent to which young people know about the policy, that I would not be able to tell you, but I can safely say that probably very few know about the policy and how it is being implemented. And hence we have all these rising numbers of HIV new infections. In terms of rehabilitation centers, only now we have just started having some at the regional level. And I don't think we have many rehabilitation centers aside from the one that is going to be established in Lusaka. Otherwise, any rehabilitation that takes place, it's linked to the mental health units in hospitals. We don't have or maybe we have one or two, I think of one or two private rehabilitation centers, but we don't have public rehabilitation centers. Most rehabilitation takes place in the hospital. The 8th National Development Plan, yes, now the 8th National Development, health is at the center. It's one of the things that are part of the 8th National Development Plan. And when we talk about health, so all the other things that interfere with one's health, like drugs and alcohol abuse, these are some of the things that we all have to pay attention to. It's got the development plan has got different clusters, and health is in what they call the social cluster. And in that social cluster, yes, there are some indicators which are related, I think, to alcohol and drug abuse. I don't know, Gabriel, if you're online, maybe you might wish to add to what I've said. Gabriel Lungu. Okay, maybe he's dropped off.
Okay. No, I think that was, I think that did speak speak a lot to the question by Bupe. There's another question, potentially the last question. Nomaswaz, you want to ask the question, please? Nomaswazi, you want to ask the question?
Good afternoon. Sorry, technology just attacked me a bit.
Okay.
I just wanted to find out, in countries like South Africa, there's a lot of gang-related activities that expose our young adolescents and the youth to drug abuse and, you know, all the issues that we have raised. I just wanted to know if this is something that is common, sorry, in the countries that you have studied, and if there is some commonalities, is there or are there programs that have been put in place that maybe other countries can also learn from in order to combat such, so that our youth can be, you know, prevented or preserved from, you know, being part of such activities? Thank you.
Thank you very much, Namasazi. You raise a very important question. Gang-related activities, I think it's not only in South Africa, even in Zambia and many other countries, you know, and usually they are related to poverty. You know, when poverty levels are high, you start getting these gang-related activities as one way of generating income. From the best practices that I read, I didn't quite get a best practice, see a best practice where gang-related activities are incorporated. Maybe this is something that you know, might wish to take up, because definitely nearly all gang-related activities are related to drug use. And the only way is, I don't know, you know, safe places like the church, the schools, and also even home, you know, it all starts in the home. So if there is disharmony in the home, if there are problems in the home, children, especially young people, will go outside to find what do you call it? People that they can look up to. And unfortunately, they start looking up to gangsters, because the gangsters, you know, they have easy money, they have an easy life, everything is easy. So yeah, there is a strong relationship between gang-related activities and substance abuse. What can we do about it? I guess it's the issue of supply reduction, you know, where these drugs, I mean, if we reduce the supply, the drug trafficking, or even if our alcohol policies, if the law enforcement officers, you know, especially the example, I think that was Nigeria, you know, was it Nigeria? No, Namibia, where they have these, where they have called these committees, which are multi-sectoral with police officers and so forth. You really need to be on top of things, monitoring these shebeens and these bars and so forth, because in most cases they tend to be placed near schools, maybe even near churches, you know, and they tend to be in poverty-stricken settings, because that's where all these frustrated people might be. So I don't think I have a good answer, except to say this is something that needs, you know, further in-depth studying and trying to see what other countries are doing. Like I said, it's about supply reduction, it's about reducing demand through increased awareness, education, or whatever. And it's also now the ones who are addicted, it's about harm reduction, helping them to recover.
Thank you, thank you, thank you. I think we've gone slightly above our time, so let's bring the discussion to a conclusion. Thank you very much, Dr. Osborne, for sharing this on this very important public health topic. You are right. You are very right to say that mental health sometimes is put behind and not very much focused on. But I really liked the interface between, use, misuse, abuse of drugs, and how that can be a catalyst for HIV infection, and then how mental health challenges then sets in. And we know that the youth, young people, adolescents, and young people are the future leaders of the world, of this continent. So really, we need to emphasize the value of public health interventions in critical areas of need, like in substance use and abuse and alcohol abuse, so that they can be protected and we have productive future leaders that can propel this world to more development in time to come. So thanks very much to the audience and everyone who participated and those who asked questions. I very much would like to say thank you on behalf of Stellenbosch University here, Faculty of Medicine and Health Science. I want to wish you all the best and have a blessed afternoon. Thank you.